Welcome to Virtually Pink. I'm Dr. William Tobler. Thank you for joining us this evening. As you can tell, I'm wearing pink, but I'm also a real man who wears pink. You may be asking yourself, what is real men who wear pink? We are part of a fundraising campaign with the American Cancer Society, an innovative campaign where men throughout the country in different communities raise money for awareness, for treatment, for research, for breast cancer patients. So I ask you to please join us this evening as we discuss breast cancer with a couple surgeons and our patients. I also ask you to consider donating to us in our fundraising campaign. There's links into my Facebook page. We also have a silent auction that ends tomorrow with some incredible gifts. I want to thank our donors and our sponsors and those who have already donated to the campaign. So if you give us 1 second, we will begin with our first section. There will be several sections tonight discussing all the topics of breast cancer surgery. Thank you. So I want to thank everybody for joining us again. My name is Dr. William Tobler. I'm a plastic surgeon at TriHealth. A fair amount of my practice is reconstructive surgery. Joining me right now, I have Dr. Ann Koritsky, who's also a breast surgeon, and Jacqueline Wrench, one of our patients. Jacqueline, a couple years ago, felt a mass and was diagnosed with breast cancer. We're going to talk to her about those experiences and what she went through. Thank you, Jacqueline, for joining us. Thank you for your courage. Thank you for sharing your story with everybody that's out there.
Thank you for having me.
So please tell us what happened in 2019.
So in the spring of 2019, I felt a mass in my left breast, and I initially kind of just fluffed it off that it was nothing. It wasn't a big deal. I had 2 fibrous tumors removed from my breast, one from each breast many years ago, and they had said with dense breast tissue that could be something that I experience again. So I brushed it off a little bit because I thought it was nothing, but I think I was also scared to investigate it. So I waited a few months. I'm a mom, and I let my kids' activities and things come first, and then I finally decided it was time to investigate. So I called my OB, and from there, I had a mammogram.
And what did that mammogram show?
They did a diagnostic mammogram, so along with the traditional mammogram, I had an ultrasound, and that I had a consultation afterwards, and the radiologist said, we are very concerned that this is cancer.
So you were connected to Dr. Koritsky.
I was, yes.
Dr. Koritsky, what happens when a patient comes to you with this situation?
Yeah, so typically my partners and I try to see newly diagnosed patients within 24 hours of them receiving the news. So as you might imagine, they're walking in the door, still processing this new diagnosis. We see a range of emotions, fear, anger, disbelief. We see shock quite a bit. So that first consult, we really try to spend time educating the patient about breast cancer in general, talking a lot about treatment options, particularly as it pertains to their specific form of breast cancer. Obviously, it can be very overwhelming, and that's just the first step in the journey.
In Jacqueline's case, you ended up recommending that she have a mastectomy. When patients have mastectomies, what happens?
Sure. So, the decision for mastectomy is not one that we recommend lightly. That's something that gets recommended based on a multitude of factors that would include the size of the cancer that we're dealing with, the size of the patient's breast, and then obviously there's a large component of personal choice as well. When it comes time to actually do the mastectomy, what that entails is essentially removing all of the breast tissue on that side. That can be done in a variety of different techniques and often paired with reconstruction.
So when you see a patient and you decide that they may need a mastectomy, or the patient chooses they want a mastectomy, you refer them to plastic surgeons?
Absolutely. I think it's really important that patients that are recommended to have a mastectomy have the opportunity to meet with a plastic surgeon and discuss all of their reconstructive options.
So in your case, Jacqueline, what were your thoughts when you found out you needed to have a mastectomy?
Well, I think by the time I had my first consultation with you, I think I was still in disbelief that I needed a mastectomy. The original treatment plan was going to be a lumpectomy, and then after further investigation, we decided that the mastectomy route was the best option. So I think when I met with you, I felt like I was still in shock and maybe exploring my options.
Mm-hmm.
And then after we had our conversation, it kind of hit me like, this is real. Like, I'm going to lose my breast.
So part of my practice, as I discussed, is very heavily involved in breast cancer reconstruction. So I see many patients who are overwhelmed. They're going through a lot of emotions, as you were, Jacqueline, and you're meeting with a lot of doctors. You're meeting with oncologists. You're meeting with surgeons. You're meeting with geneticists to find out if you have a genetic carrier, which we'll get into. And I do want to say, if you have any questions, please type them into the feed and we'll get to them at the end of our discussion. So when you come into my office, I have a lot of information already in hand from Dr. Koritsky and her partners and breast surgeons about what the plan is. And so we go through various options for reconstruction. In your case, we used implants, and we did an implant-based reconstruction. And these are some examples here of the implants that we use. There's silicone, there's saline. Sometimes it's possible to put an implant in immediately at the time of the reconstruction. But in most cases, we have to actually do a staged procedure. This is because the skin after mastectomy may not be healthy, or there may not be enough skin. So we use this device called a tissue expander, which is essentially like a balloon that has a small port in it. At the time of the mastectomy, most often, we place this under the skin or under the muscle, and it heals into place, and you come to my office, and we slowly expand the skin over time. And this is how we recreate the tissue for a reconstruction. And one thing that I tell patients, it's kind of nice that they have some control over the final size. So during the consultations, we'll fill up the tissue expander, and once we come to an agreement on size, and we can go back for a second, simpler operation where we put in the final implants, silicone and saline. There's always a million questions about what is the safest option. Are implants safe? And the answer is they're very safe, and they've been studied probably more than any implantable device in medicine out there. There have been issues over time, but the technology's improved, and it's still improving, and we're still learning a lot about it. But we have a lot of success reconstructing breasts with implants, and in fact, it's the most common way that breasts are reconstructed. And later today, we'll talk about other options for breast reconstruction as well. So, actually, could we show the slide? This is a small cartoon that describes what happens with the reconstruction. In the cartoon here, the muscle is lifted, and underneath it is put the implant or the tissue expander. And sometimes we use an extra donated tissue to help reconstruct the inferior pole of the breast, which is that white piece of tissue that is on the left side of your screen. And the implant stays in place here. There's not necessarily a shelf life. Often you hear 10 years, but we monitor the implants over time. And if you need an exchange at some points in your life, then one implant is taken out and another one is put in. But these are usually fairly simple operations. So Jacqueline, back to you. You rolled into Bethesda North Hospital. What were your emotions? What were you thinking that day that you were undergoing this surgery to have both your breasts removed?
I was terrified. If I'm being honest, I was terrified. I guess I wasn't as concerned about the pain that I would experience afterwards. Of course, that did cross my mind. For me, it was just what would be found. Would they find that cancer had ravaged my body? Would it be contained? I still had a lot of questions in my cancer journey, and this was the first exploration of what was really going on. So I also had the burden of just worrying about my family, because I knew that I would be unconscious through the procedure, but they would be waiting a lengthy time in the waiting room, probably very scared and worried about me. And so that was tough.
You're a mom with 3 young kids.
I am.
How do you explain that to them?
we had a frank conversation with them. Cancer is a big word for a kid. And they hear that and they essentially immediately equate that with death or with something, and adults do too. So we had a conversation with them. We sat around the dinner table and let them ask questions, and we just tried to be very open with them during my journey and let them ask things when they were comfortable asking them, and not talk about it when they didn't want to.
Dr. Kritsky, when you do a mastectomy, what do you do in the operating room?
Yeah, so I have the task of beginning the operation before Dr. Tobler comes in and does his reconstruction. My job in this case was to remove as much breast tissue as physically possible while maintaining all of the skin so that could really serve as an envelope for the reconstructive process.
Great. What was your recovery like in the hospital? You stayed a night in the hospital?
I did. I stayed one night in the hospital and was happy to go home the next day.
You had some drains?
I had drains. They were bad. I know you heard me complain about them a lot. Physically, that was the worst part of the recovery for me. That and just having to sleep in a recliner and not being comfortable. For me, really, the worst part of the recovery was the emotional toll, the mental aspect. The mourning of losing something that had made me a woman, something that had fed my children, and that was hard. That was tough. Physically, I got through that pretty easily, but the emotional toll is still very raw.
Did you need chemotherapy?
I did not. I didn't require chemotherapy or radiation.
Dr. Kritsky, how does one find out if they need chemotherapy?
Yeah, I would say this is probably one of the greatest advances we've really had in the last decade in breast cancer treatment. Historically, the majority of breast cancer patients would require chemotherapy as part of their treatment plan. And that was based on a pretty straightforward set of criteria that had to do with the size of the tumor and whether or not there was lymph node involvement. Recently, there's been dramatic research around this area, and we've actually been able to spare a number of patients chemotherapy. The decision is now really more based on some of the characteristics of the tumor itself, the receptor status of that tumor, as well as we're now looking specifically at the genes of the tumor to determine whether or not chemotherapy is necessary.
Are there new chemotherapy drugs coming out? Are we still using the same ones for the last 20 years?
Yeah, so some of the medications have remained the same, but there's also newer medications being developed, specifically more targeted treatments, antibody-based treatments.
Okay, and do all patients lose their hair with chemotherapy?
Well, many of the chemotherapeutic agents do still cause hair loss. We have one option at our breast center. It's called a cold cap. And that's been a program that has helped many patients retain their hair while undergoing chemotherapy.
Wow. Once a patient has a mastectomy, do they still get mammograms?
Actually, we no longer recommend mammogram of that breast. That's a question that's been studied for a while, and we actually found that it did not add much over just physical exam. Mm-hmm. So I still follow my patients for 5 years after their cancer treatment, but we're doing periodic exams to check for any concerning signs rather than getting mammogram.
Okay, and do the family members, once someone has a mastectomy or is diagnosed with breast cancer, do all the family members need to get checked out?
Sure. So a big driver of that particular question is going to be the genetic information that we checked on the patient. And so Jacqueline went through genetic testing, particularly given her young age at diagnosis, and thankfully did not have any mutation associated on her testing. So in those cases, we still recommend that family members have awareness and follow appropriate screening guidelines. But no further genetic testing was going to be recommended to them.
And is it possible to get breast cancer after you've had a mastectomy?
So unfortunately, there's no guarantee with mastectomy that we can't have a recurrence. However, thankfully, that risk is extremely low.
Great. All right, Jacqueline, back to you. So you had your first surgery, you had the mastectomy, you recovered from it, you underwent the tissue expansion process, and then you made a decision, and we talked about this in the office. We discussed silicone and saline. Both I offered to my patients. You decided on one over the other.
I did.
What did you pick?
I chose a saline implant for a number of reasons. I knew that I would get maybe a little bit more of a natural feel with silicone, but I also had the concerns of it leaking or needing to be replaced at some point, and having to follow up with MRIs. That wasn't something that I wanted. More doctor's appointments was something I was trying to avoid, I guess. So it just gave me more peace of mind to go the route of the saline.
How was the second surgery compared to the first?
It was much easier. The worst part about that was the fat grafting site. Otherwise, there wasn't much pain, and I was.
So you had a little bit of liposuction. The fat was borrowed from one area of your body and
Yes.
put up here, and that's a technique that we use to help kind of soften some of the tissue planes or fix small deformities. Okay. Well, I think that kind of wraps it up. Is there anything else that you have to say, Dr. Kritsky or Jacqueline? Well, I want to thank you guys both for your time, for your bravery to be here to discuss all that you've been through, and to be really vulnerable, because it's hard to do, but it helps so many people and it answers a lot of questions for those out there. So thanks again, and we will transition to our next group. And while we're doing that, I just want to remind you again, please consider making a donation to our Real Men Wear Pink campaign. There's links in my Facebook page. You can visit my website, drtobes.com. And there's also a silent auction. It's online and it's open till tomorrow at 5 p.m. And there's just some amazing donations from our group that's around here. So thank you again to all the donors. All right, I'd like to welcome you guys back. For those of you who are just joining us, my name is Dr. William Tobler. I'm a double board certified plastic surgeon at TriHealth. And joining me here are Dr. Barb Wexelman, who's a breast surgeon at TriHealth, and Liz Woodmansey, who is a breast cancer survivor and patient. So thank you guys for joining us. Thank you, Liz, for sharing your story, for being so brave, and for explaining how this whole process went for you. So you had just a screening mammogram.
Yeah, my yearly checkup.
Your yearly checkup. So once you get 40, depending on the recommendations, you get a mammogram every year. Tell me what a mammogram's like.
To be honest, it's uncomfortable.
Mm-hmm.
There's a lot of pulling and a lot of smashing, but it's a minor inconvenience. The pain doesn't last. It's not, you go home and you don't even realize you've had it. There's no bruising, but it made the big difference.
So you just came in for your screening mammogram. What happened after that?
They called me back for another visit. They were concerned about 2 places, and I went in and had a diagnostic mammogram, and then a ultrasound,
Mm-hmm.
and then
A biopsy?
the
This led you
biopsy
to a
was
biopsy.
later.
And then you got connected to Dr. Wexelman.
Right.
So Dr. Wexelman, you see a lot of patients who were just having their screening mammogram and something was found. What happens when that occurs?
Exactly. We have a very great screening program here in Cincinnati and at TriHealth, and our radiologists are outstanding. So luckily, Liz's tumors were caught on her mammogram. After the ultrasound was also abnormal, she was instructed to have a needle biopsy. So that's where the radiologist numbs up the breast with sort of Novocaine, and then uses a needle and then either an ultrasound or the mammogram machine to do an image-guided biopsy of that area.
Do most women feel a breast cancer, or are they usually found on screening mammograms?
That's a good question. Many women, we do encourage women to know what their normal breast feels like, and certainly if they feel a lump or a change, to call us and have it get checked out. But most of our population here at TriHealth, their breast cancers are diagnosed from mammograms. So it's really important to go for these preventative tests.
And when is that recommendation made?
It's a bit controversial. Currently, the American Cancer Society and the radiology societies and our institution still recommend women start mammograms at age 40. Some other national societies have changed it to 45.
Got it. And in Liz's case, she was diagnosed with an invasive breast cancer, but there's also non-invasive cancers. What are the differences between the two?
Exactly. So in non-invasive breast cancer, ductal carcinoma in situ, we refer to that as DCIS. I try to explain to patients as that's a stage 0 breast cancer. Most of what you hear about with breast cancer, pink ribbons, chemotherapy, that kind of thing is usually stage 1 to 3, and then metastatic breast cancer stage 4. DCIS is when the cancer cells are present but confined in the duct of the breast, and invasive cancer is when they've spread outside the duct. So they have the capacity to spread through the body or to the lymph nodes, that kind of thing.
And in cases of low-grade tumors or DCIS, patients can have a lumpectomy or a mastectomy, is that correct?
It somewhat depends. Some patients have a very large tumor, either stage 0, extensive throughout the breast, or a small breast, and so a lumpectomy may not make sense. That's why we really try to customize the treatment plan to the patient. When I saw Liz in the office, even though she had 2 tumors, she had a very large breast, and she had also had a lot of weight loss, so I felt that there would be opportunities to combine her surgery with the plastic surgery approach to give her the best cosmetic outcome possible.
As far as outcomes go, does a lumpectomy or a mastectomy have a better survival rate or a better chance of cancer not coming back?
As long as we get all the cancer cells out, we get all the cancer cells out. The patient's body doesn't really care how much healthy breast is removed around the tumor. Of course, if we leave a breast in place with a lumpectomy and just remove the tumor, there's a slightly greater chance of the tumor coming back, but that's why most of those patients go on to get radiation.
So patients don't just have a lumpectomy, they usually need additional treatment beyond that?
Usually, except if they're very advanced age and some other genetic conditions, but most patients who undergo a lumpectomy are offered radiation therapy and then potentially even anti-estrogen oral therapy like tamoxifen.
And is the recovery from a lumpectomy the same as a recovery from a mastectomy?
It's usually much shorter. It's an outpatient procedure. The patient goes home the same day. They may not have any drainage tubes in place, and they're usually back up doing their normal routines within about a week or so. Was that your experience?
Yes.
As a breast cancer surgeon, are you doing more lumpectomies? Are you doing more mastectomies? Is it a mix?
It's definitely a mix, and again, certain patient situations may indicate a mastectomy would be a better choice, but we really try to offer lumpectomy breast conservation first for nearly all patients if we can.
So you briefly touched about this. Some patients who have lumpectomies need or can have a plastic surgeon involved, but in most cases you don't.
Right. Most patients who come in with a medium-sized breast and a small to medium-sized tumor, we don't necessarily get the plastic surgeon involved, but there's lots of different situations. Patient may have had cosmetic breast implants in the past, have had a significant weight loss, could use we call it oncoplastic breast reduction, other kind of considerations to help with the overall cosmesis for the patient.
So Liz, you pursued the option to meet with me with a reconstructive surgeon, a plastic surgeon. So you felt like your breasts were a little too large and this was an opportunity to treat that along with the tumor, correct?
Right.
So what kind of problems were you having before you even were diagnosed with breast cancer?
The weight on the shoulders, the back issues, just the general uncomfortable, doing any kind of physical activity from just the extra weight and pull and having to have heavy sports bras and
Sure.
uncomfortable.
Yeah, it can really cause neck pain, back pain. You can get rashing and things like that. Can we go ahead and put the slide up that describes what happens here? So as a plastic and reconstructive surgeon, there's opportunities where we can take a certain breast and reshape the breast and fill that hole that was taken out from the tumor and either make the breast smaller or just give it a more natural shape. So a lot of times when patients have breasts that are too large for their body, which happens very often, we see the patients. And I think one of the things that's nice about this is after a patient has radiation, if they have the lumpectomy, they had large breasts and they had radiation, it's very challenging and the risks are higher to do any type of surgery after that. So as a plastic and reconstructive surgeon, if a patient feels like at some point in their life they need to have a breast reduction, the time to do it is at this lumpectomy. So we have a program here where we work very closely with all the breast surgeons and have the opportunity to combine these surgeries and do it at the same time, or in a delayed fashion, but in most cases we do it at the same time. So Liz, you came in your day of surgery. Did you stay a night in the hospital?
No.
So you went home the same day.
And she
So-
lives far away.
Yeah, she does. She came and visited us from several hours away. So please describe what your day of surgery was like.
Oh, it was really scary. It was, well, first I met with you the week before quarantine. So that was the last contact with anybody without a mask. So when I went into the hospital, my husband dropped me off and my daughter, and I went in
Because there
by
were no
myself.
visitors.
Right, and I went in by myself. And it was kind of eerie because the hospital was kind of empty. And, but surgery, to me, it went quickly. I know I was out a lot, but it was over, and I went home, and the day of surgery kind of is a memory right now.
Did you have pain or discomfort after the surgery? How was your recovery when you were at home?
There was slight pain, more of the emotional, mental of looking at the scarring and everything was what hurt, what did the most, had the most effect on me. But the pain was manageable. I did have a drainage tube, and that wasn't a lot to take care of. But afterwards, pain was minimal. I was up probably in a week feeling
Good. So you're up
good.
moving around. You were walking
Yeah.
the same day, and you had some swelling and discomfort, but things settled over time. And then because you had the lumpectomy, the recommendation was for you to have radiation, correct?
Yes.
So describe what that was like.
Well, that first there was nothing. I went home and I didn't know. It's like, did I have radiation? It built to the final, I think there were 16 days of radiation. And
You just come like 16 days in a row?
except
or?
for weekends.
Okay.
So, and then it was, Monday through Friday, except, Saturday and Sunday off. And the last few days, it started to hurt, burn. It was like a severe burn. But the lotions and the different ointments, actually, I kind of used aloe that helped, fresh aloe helped the most with it. But it was just a lot of, just mostly like a severe sunburn. But other than that, it wasn't uncomfortable. It didn't last but a few minutes at a time, every day.
So when you get radiation, what happens? You just come into an office, or is it in an operating room, or how does that work?
I went into the office at Good Sam and went into the radiation room, and they had the first week before I started radiation. I went in and they did all the measurements and markings, and I had X's here and there, and when I went in for my normal radiation, they lined me up, and they started. As soon as I got on, they started, and within a minute, 2 minutes, I was finished, and on my way home.
Dr. Wexelman, do you work closely with radiation doctors, or how does that work? Does the patient need to find their own radiation doctor?
No, we're a team. So we're a breast cancer treatment team, and we have different doctors at different facilities. And so we try to pick a facility that's closer to where patients live, because so much of radiation is driving back and forth. But we work together as a multidisciplinary team. So Liz saw the doctor that I routinely work with that takes care of the majority of my breast cancer patients to perform her radiation.
And what does Liz have to do now that she's had her lumpectomy, she had her radiation treatments? What is the follow-up?
So the follow-up is really she's in survivorship mode. So interestingly, she'll only get a mammogram still once a year. Mammograms have radiation, and we try to limit how often you get mammograms. Some patients think they need extra mammograms after breast cancer surgery. She'll get mammograms once a year a visit with me, as well as visits with her medical oncologist and her radiation doctor.
What is the chance that she could get breast cancer again?
It's complicated. I think the fact that she did the radiation, and if she's taking the anti-estrogen pill, the chance of her having a recurrence is low, but possibly 10 to 15% chance in her lifetime, but still very manageable.
Can you talk about the anti-estrogen pill? Why Why does she take that? Does she take that for the rest of her life?
So most tumors are sensitive to the estrogen receptor, and there's special medication, that's oral medication patients take every day called tamoxifen or an aromatase inhibitor in women who've gone through menopause that block the estrogen receptor in their body. It can cause certain side effects like menopause type side effects like hot flashes, and some patients may have joint pains because of that. But it really has been shown to help improve survival in patients who have tumors sensitive to estrogen, and Liz's tumors were sensitive to the estrogen receptor.
And how long does she take that for?
So I tell patients between 5 and 10 years, although it's at the direction of their medical oncologist. But I wouldn't be surprised that for some patients there will be lifetime recommendations, because more and more studies show the longer patients take it, the better controlled the disease will be. So at least 5 years.
Are you still taking this medication, Liz?
Yes.
And do you have any side effects from it?
The hot flashes, which I did not have before menopause, I do have now, and at all hours of the day and night. But other than that, that's the only side effects that I've so far.
So you're now a breast cancer survivor. You've been through surgery. You've been through the radiation. What was that journey like?
It was very, very scary. Going through it with the COVID and the fear of having to have chemo. I had to wait for the testing of the tumors to before I was told if I had to have chemo or not. It was a lot of waiting to see the course of treatment, but mostly just fear. And then once everything was over, and radiation and the healing process had begun, just a relief that I found it early, and I just can't imagine if I had put off having a mammogram.
The American Cancer Society predicts that there's going to be 240,000 cases of newly diagnosed breast cancer this year in 2020. So there's a lot of women and some men out there who are just battling with this now, just getting their diagnosis or going through the treatments. What are some words of advice or wisdom or encouragement you can provide to them?
Don't wait. If your yearly mammogram, don't put it off. I can't imagine it having to put it off a year or two, and what more would have that happened? How much more surgery or more treatment I would have had to have if I had put it off.
Well, I want to thank you, Liz. I want to thank you, Dr. Welkseman. Thank you for sharing your story, for providing those words of advice for people that are out there. It's really amazing that you can do this and be so open about such a personal topic, so thank you very much. All right, so we're going to transition to the next phase of our presentation, Virtually Pink. I want to thank you guys all again for tuning in. Please consider making donation to Real Men Wear Pink. There's links on my Facebook page. Also, we have a silent auction that's running. There's a link for this as well, and it'll end tomorrow. There's incredible donations, and I want to thank all the sponsors and donors who have already contributed to this campaign, so thank you very much. So for those of you who are just joining us, I want to thank you for tuning in. My name is Dr. William Tobler. I'm a double board certified plastic surgeon at TriHealth. I'm joined here with Dr. Katie Rocky, who's a breast surgeon at TriHealth, and Stacy Durbin, who's one of our patients here at TriHealth. So thank you all for joining us. Thank you for your courage and your bravery, Stacy, to talk about the issue. Yours is slightly different than the previous two patients. You did not have a diagnosis of breast cancer. You've never had breast cancer, correct?
Correct.
So what brought you to us? Why are we here talking about breast cancer with you?
Yep, so I found out that I am BRCA2 positive, which is a genetic mutation. It predisposes me to breast cancer and a few other cancers. I found this out. My maternal uncle was diagnosed with prostate cancer, and his surgeon decided to do genetic testing, found out he was positive. From there, his first relation relatives were tested, being my mom, and then I was tested. And so far, of the 13 members of our family tested, 11 of us are positive.
Wow.
So with that information, I had to do something. I felt that I needed to do something.
So what is, Dr. Rocky, what is BRCA or BRCA?
So BRCA is a genetic mutation that some patients carry, and it puts them at an increased risk of breast cancer over their lifetime. So if the average woman comes in with no mutation, no family history, no risk, and we tell them their risk may be at 10 to 12% over the course of their lifetime, BRCA carriers, of which there are two types, BRCA1 and then, as Stacy alluded to, BRCA2, their lifetime risk is increased up to 55 to 60% compared to someone who is not a genetic carrier.
When are patients typically diagnosed with BRCA?
A lot of our patients are diagnosed with BRCA in a couple of different ways. For some of our patients, they are coming in with a diagnosis of cancer, a known family history, and they're getting testing that way. Or as in Stacy's case, they potentially have no prior history of a cancer, but they have family members who have been tested. And so at TriHealth, we have a genetic counseling program that helps us get those patients worked into that pipeline.
So someone like Stacy walks in, they're diagnosed with BRCA, or some other genetic mutation. Does that mean they need to have a mastectomy?
Not necessarily. So the way that we counsel patients has to do with the type of mutation they carry, what their overall risk of a breast cancer is. Certain patients, for a lot of the genetic carriers, one of the things we can talk about early on is how we monitor them a little bit differently. In addition to just an annual screening mammogram, for a lot of patients we talk about adding in using MRI to image the breast. For some patients, we talk about using medications that can help reduce their risk. And then for other patients, some lifestyle modifications, things that they can do, changes in their diet, changes in exercise habits, decreasing alcohol intake, eliminating smoking, that can decrease the risk of developing a breast cancer. But for other patients, for example, Stacy, BRCA2 mutation, BRCA and some others, we actually know that there is a benefit to surgery and to reduce the risk of developing a breast cancer, so that becomes a part of the conversation that we have.
Does BRCA just affect the breast?
No. BRCA can affect not only the breast, it can affect the ovaries, it can affect the pancreas. There can be an increased risk of melanoma for those patients. Also, for male carriers of a BRCA mutation, it puts them at not only an increased risk for male breast cancer, but also prostate.
So Stacy, you found out you had BRCA, you started investigating it. What did you find, or what did you determine you needed to do?
So for me, I decided I'd already had my children. I was given this opportunity to be very progressive and very proactive, and I decided I was going to go with a mastectomy. So I started my journey a little differently. I started looking first at for plastic surgeons, and then went to the breast surgeon route.
Is this what happened with Angelina Jolie?
So this is an issue that she popularized. She has been very open about the fact that she is a BRCA1 carrier, and her decision to prophylactically remove both of her breasts, a lot of it based on her personal experience of watching her mother battle ovarian cancer and eventually succumb to it.
So Stacy, you wanted to find the right plastic surgeon because you wanted a certain procedure, correct? What were you looking at? What type of reconstruction were you looking for?
Correct. So I was amazed at all the different reconstruction options available. It was slightly overwhelming. I'm a big advocate of educating myself, and I probably over-educated myself. At the same time, I'm going through this journey. 2 other women in my family were too. So we compared a lot of notes. I decided for me, I wanted to explore the deep flap reconstruction process. A couple different reasons. One, because I was younger, I didn't want to have to take the risk of having to swap out implants in the future. I wanted one and done. And then also I liked the idea of using my own tissue.
Got it. So if you don't mind, we'll pull up the slide. So for those of you who are listening, Stacy talked about a deep flap. It's an abbreviation DIEP. It stands for deep inferior epigastric perforator flap. And it's a complicated word, and this is a complicated diagram that oversimplifies exactly what happens. But in the right patients, you need to be screened. Not all patients are unfortunately candidates for this surgery, but Stacy was in our case. Some extra tissue from the belly is removed, and it's a very delicate and technically challenging operation in which small 2-3 millimeter blood vessels are dissected free from their larger blood vessel, and it's actually, this tissue is transplanted from the belly to the chest, and a breast is reconstructed using that. And the way that the tissue survives is that these small blood vessels are attached to blood vessels under some cartilage. So we remove some cartilage and find some blood vessels near the lungs and the heart, and we attach these vessels. And this is a successful way to do breast reconstruction. It is a process that has evolved over time from something that you may have heard of called a tram flap. And essentially, we've found ways to remove less tissue from the belly to make it safer for the patient. This surgery compares and contrasts a little bit to the implant surgery because it's a much longer surgery. This can take 12, 14 hours sometimes to do 2 breasts. It can be faster in some hands, but there is variation across the board. Not all plastic surgeons do perform this. It's not the most common way that it is done, but in the right patients, it's a great option. So in the case of Stacy, she was a candidate for this operation, and this is the operation that she decided to choose. So back to Dr. Rocky real quick. When patients have BRCA or even just some kind of breast cancer, there's something called a multidisciplinary clinic, or please tell me what that is here at TriHealth.
Yeah, so for our cancer patients, we do have a multidisciplinary clinic. As both of my partners have alluded to, that's an opportunity for patients to work closely with medical, radiation, oncology, genetic counseling. For patients who have never had a diagnosis of cancer, but who have a known genetic mutation that places them at increased risk, we have a hereditary multidisciplinary clinic. And really what that affords the patient is an opportunity to meet with multiple specialists so they can discuss what their risks are and then discuss follow-up going forward as to how best to surveil them.
Great. So with all these doctors involved, Stacy chose her plan, you chose your surgeon, you chose your breast surgeon, and you underwent the DIEP flap. Please tell me, what was that like the day that you came into surgery? What was your recovery like?
I had never undergone any surgical procedure before, so I did not know what to expect, but it was intense. And I knew that going into it. I chose the DIEP flap. I knew it was more intensive in the beginning, and that was what I elected to do. The day of surgery, of course, like anyone else, I am excited, I'm nervous, I'm frightened. The night before, you have to wipe down with these chemical wipes, which were really sticky and not feeling very well, but that's part of the process. Get there that morning, everyone was wonderful. You were way too happy in the morning, I must say for me. I had no coffee yet, but it was good, right? I mean, like all the other ladies said, we were asleep for it, so you worry about your family coming out of it.
Mm-hmm.
So the day of surgery was a long day for everyone but me.
Do you remember, waking up, or was it the next day that you remember?
Yeah, so again, it was a pretty intensive surgery. So I spent, I think, the first 2 days in ICU, not due to complications, but as you said, I needed that monitoring of the flaps. I spent 2 days in ICU, I think 5 days total on the floor. It was intense. I am very thankful that I had the care that I had and that I was in a hospital setting. I was restricted on my movement. I was in what you called a beach chair position, which made it sound much more exciting than it was, but basically I couldn't straighten out my torso. So I'm glad I did it though.
Yeah, you're right. It is a much more intense operation, and that's why we have to select the right patients for it, to young, healthy, and have the right tissue distribution. So you were that candidate. You underwent the surgery. You had a very successful surgery. Everything went fine. You went home, no complications. And did you have any other surgeries after that?
I did, yes. So going into this, I had fully expected to have at least one revision or touch-up surgery. I've had now 2, and I have another one scheduled later in December that's actually with another physician, Dr. Basil at TriHealth, to help mitigate the ovarian breast cancer. We're going to do both of them together.
So you have, what are you having done?
I'm having my fallopian tubes removed.
Got it.
It's thought the ovarian cancer starts in the fallopian tubes, and since I'm not quite to menopause yet, I'm going to try to mitigate it with the fallopian tubes.
So have you been happy with your results?
I am. I'm very happy. Each round of the revision surgery I've done, I've come out of it happy with the way things are looking and the way things are progressing.
So why did you do the revisions? Is it because you were unhappy, or you wanted improvements? You felt like there could be some subtle improvements? What was it that drove you to ask for more surgery?
Yep, so a lot of it was the tweaking of the improvements. The very first one, things didn't quite look the way I thought they should, but again, that was expected. I knew that going into it. Beyond that, there were just little tweaks, and also, candidly, it's fat grafting, so you get a little bit of liposuction out of it too, which is not what it's intended to be for, but I've had 2 kids, so that's what we're going with.
Silver linings.
Got it.
Yes.
So you've done your research, you know about BRCA. What's your advice to women out there who have been diagnosed recently or are not really as aware of as you are of the diagnosis?
Like I said, I'm a big advocate for educating yourself. So I would definitely educate yourself. There are some really good websites out there, some tools, some resources. You can talk to your physicians, but you have to make the right decision for you. I have several members of my family going through this. I decided to do the mastectomy with reconstruction. I have other family members that have decided to do monitoring or other things. And really, it's educate yourself and do what you feel is best for you and your family.
Well, I appreciate your time. I appreciate you for sharing your experience. Thank you, Dr. Rocky, for sharing your expertise on this field. I want to invite everybody that's out there that's watching, please ask questions, because we're wrapping up the patient segment, but I'm going to bring the other breast surgeons back and we're going to answer some questions. So just hang tight for 1 second, and thank you, guys.
Thank you.
So one last reminder, and thank you for joining us. Thank you for tuning in. Thank you for those who have donated and are considering donating. There's links on my Facebook page. Please consider making a donation. This money goes directly to the American Cancer Society. It goes to patients. It helps them get transportation to their treatments. It helps with a night in a hotel if they need it. It helps with research. So this is going to impact patients right away. And your contribution is greatly appreciated. This is October, it's Breast Cancer Awareness Month, and so thank you. All right, so for those of you who are just joining us, I want to bring you back and thank you. My name is Dr. William Tobler. I'm a double board certified plastic surgeon here at TriHealth. I'm now joined with my colleagues at TriHealth, Dr. Ann Koritsky, Dr. Katie Rocky, and Dr. Barbara Wexelman. They're all breast surgeons in the TriHealth Cancer Institute. And this is our opportunity now to kind of wrap things up and answer some questions that we have from the audience. So we're just going to start going down the list and answer those. So please just put them into the Facebook page and we'll go from there. So we talked about actually the first question. If you carry BRCA, do you recommend a preventative mastectomy?
So I think kind of like what Stacy had been alluding to is that that's a very personalized decision that we work with the patients to help them make that decision. As Stacy said, for some people, it is more appropriate at where they are in their lives to do maybe more increased screening. But for those patients who are ready to take that step, maybe it's based on ages at what they've seen other family members diagnosed. Maybe they're done, as they said, they've done childbearing, they're not going to be breastfeeding. I think it's one of those things that we kind of tailor to the patient and their needs at the time.
Great. Does insurance cover breast reconstruction? I get this question all the time. And I would say in my experience, 100% of the time, yes, they do. In 1998, Bill Clinton passed a mandate that basically requires the insurance companies to cover the reconstruction. Once in a while, I've had some issues, but I've never ultimately not been able to provide a reconstruction for a patient. So this is something we can figure out during our consultation, but it's almost always covered by the insurance company.
I would say also revision surgery after a lumpectomy is often usually covered by insurance companies as well once a patient has had a breast cancer diagnosis. So I see patients who maybe had surgery 15 or 20 years ago and one breast is a lot larger than the other, or one breast is lifted up after radiation than the other. And those are also patients who it's important to plug them in with a plastic surgeon to see if there's something to be done to improve their cosmesis that will often be covered under insurance. And patients don't necessarily think so.
Great. I'm going to read this question here. How important is the anti-estrogen medication for a patient with stage 1 HER2 positive breast cancer? If side effects from the medication are awful, what's another option besides oophorectomy? How about Dr. Koritsky? Could you answer that one?
Dr. Koritsky, sure. So, the breast cancer treatment now is multimodal, meaning that we're taking into account multiple different treatments. Oftentimes it's a combination of surgery, radiation, and medication. So medication is one piece, and its role is really to help prevent recurrence of that cancer. So certainly it is important from that standpoint. Side effects are a significant concern for our patients, and luckily there are multiple different medicines that can be done for anti-estrogen therapy. And there's some variability in the side effect profile. So often if one medication is causing a lot of side effects, they can work with their medical oncologist to trial a different agent and sometimes have more success with that.
Great. Dr. Rocky, what is lymphedema and who gets it?
So lymphedema is what can be referred to as arm swelling, and it is most frequently associated with patients who undergo what is known as an axillary lymph node dissection, where we remove all of the lymph nodes in a woman's armpit. Some years ago, we got smarter about doing less surgery to get the same information, so we started doing sentinel lymph node biopsy. That's where, at the time of surgery, we're only removing a few lymph nodes to get the same information. A lot of factors go into deciding who is a candidate for what type of surgery, but for patients who do end up ultimately developing lymphedema, which is this chronic arm swelling, we work very closely with some of our occupational therapists who specialize in the treatment of lymphedema, seeing patients both pre-operatively to establish a baseline with them, and then as well as post-operatively with things like massage for the arm, compression sleeves, some exercises they can do to reduce that risk.
Great, thank you. How long does it take to recover from reconstructive surgery? We kind of touched base on some of these, but it really depends. It depends on what type of reconstruction is being performed. Is it reconstruction after lumpectomy? Those patients often go home the same day. Is it reconstruction after mastectomy? Those patients usually stay a night in the hospital. Is it recovery after a deep flap or using tissue from some part of the body? That's a longer recovery. So it really depends on the type of surgery, but it's all over the place. And honestly, that really directs how some patients decide what surgery they're going to undergo. So I have three more questions here. I'm going to ask each one of the breast surgeons, and then we're going to wrap things up. So Dr. Kritsky, any words of advice for women out there who have not had a breast cancer diagnosis?
Sure. Well, I think our patient stories really highlighted the necessity of knowing your own body. As we heard with my patient Jacqueline, she brought this breast mass to our attention. And so the importance of knowing your body and also coming in for routine screening could potentially save your life. And we talked about that. There's some controversy over when to do it, but here we recommend at age 40 you start getting your screening mammograms. And where can they come here at TriHealth for a screening mammogram? We actually have locations all over the city for screening mammogram. Diagnostic imaging can be performed at our breast centers, so that's going to be Good Samaritan Hospital, Bethesda North Hospital, and Bethesda Butler Hospital. But we have screening available at up to 12 locations around the city. And 3D mammogram is offered at all of those locations as well. Great. Dr. Wexman, any words of advice for women who have had breast cancer and are currently cancer-free? They've undergone their treatment.
Yeah, I think it's hard for patients to get back to their old way of life, even if the scars fade and they're told their treatment's over. Sometimes emotionally it's hard to, life is never truly the same, and I tell patients all the time, that's sort of the crappy part about cancer is it can come back, but at the same time I really encourage my patients to figure out what your new normal is and to start moving, into your new normal life. And I think moving past the diagnosis of breast cancer and not being so fixated on recurrences or the next test you need to have, it's of course easier said than done, and I can't say that I personally walked that journey, but I really encourage patients to just try to get back to the things that they're used to doing, and this is just going to become a new part of your normal life.
Great. And lastly, Dr. Rocky, any words of advice for women who are currently battling with breast cancer?
I think the most important thing for those women to realize is that they are not alone. They have a lot of options. Here at TriHealth, we have a fantastic team that we are privileged to be able to walk our patients through that journey from start to finish and are dedicated to helping them the entire way.
Great. Well, I want to thank you guys again for your expertise, for sharing your expertise and trying to make it understandable for everybody that's listening in such a short period of time, because it is a lot more complicated, but I think we touched on a lot of the important factors. I want to thank the patients who were able to join us today and share their story. I want to thank all the donors. I want to thank all of you who are watching. Thank you for tuning in. Please don't hesitate, reach out, let us know if you have any questions, and I'll end with one last question. Dr. Tobler, what is your favorite part of Real Men Wear Pink? I have to tell you, it has been such an amazing honor to be a part of Real Men Wear Pink. The opportunity to be out here and to talk about what we do and to raise money for patients and to make a difference in patients' life has been indescribable. I can't really explain it, but I'm very grateful for American Cancer Society. I'm very grateful for our leader, Jeanette Altino. I'm very grateful for all of the people who are working with the American Cancer Society in this campaign and my fellow Real Men Wear Pink. So it's really truly an honor. So thank you all. I hope you have a great night, and please don't hesitate to reach out.